Good afternoon to one and all. I am Dr. Surya, pediatric resident from Apollo Children's Hospital. I am going to present an unusual case of chronic diarrhea with Untitled under the guidance of Dr. M.S. Vishwanathan sir, senior consultant, pediatric gastroenterologist in Apollo Children's Hospital. We have an 11-month-old male child presented with complaints of loose stool for the past 6 weeks, initially 3 to 4 times and 7 times for the past 10 days, which was watery and no blood stain. The child has vomiting on and off for the past 10 days, which was non-bilious and non-projectile. There was history of fever, low-grade intermittent for the past 2 days. There was poor weight gain and there was skin rash over the abdomen. There was no history of blood transfusion and there was no history of recent contact with COVID positive patients. Birth history was unremarkable with birth weight of 2.6 kg and family history also unremarkable with no family history of sudden death or no family history of liver disease or GI disease. Coming on to general examination, is alert, conscious, oriented with stable vitals and anthropometry showed weight of 8 kg, height of 72 centimeter and weight for height all comes in between 3rd and 50th centile. Head to foot examination showed mild abdominal distension, papilloerythematous rashes over the front and back of abdomen, palmoplantar erythema present, there was no scalp lesion. On systemic examination, abdomen showed mildly distended and hepatosplenomegaly was present. Other systems were normal. On summary, 11-month developmentally normal child present with chronic diarrhea for 6 weeks, generalized rash and poor weight gain. On examination, he was pale, had a generalized erythematous rashes involving palms and soles. His abdomen examination revealed hepatosplenomegaly. His neurological examination was normal. At this point, we had a differential diagnosis of malabsorptive syndrome, celiac disease, immune deficiency, very early onset IBD, and metabolic storage disease, unlikely longer-run cells histiocytosis, and chronic granulomatous disease. In outside hospital, child was evaluated for echo, which was normal, and slightly elevated serum ammonia with slightly increased transaminases. In our hospital, we had done initial investigation. In CBC showed HB of 9.4, platelet of 1.6 lakh with normal counts, and LFT slightly increased transaminases with slightly increased GGT and slightly lower side of albumin. And also INR was slightly increased of 1.27. Renal profile was normal. Lipid profile showed increased triglycerides of 300 and decreased HDL and increased LDL. Other investigations such as ammonia lactate was normal and hepatitis B and HIV were negative. PAD workup was unremarkable. Ultrasound abdomen showed the liver larger in size, shows homogeneous increase in echoes, and spleen also larger in size, which showed 14.6 centimeter. X-ray abdomen showed no calcifications in and lumbosacral spine were normal. Ophthalmologist opinion obtained no abnormalities detected, no cherry red spot, no evidence of any metabolic liver disease in the child. And gastroscopy showed moderate duodenitis, and colonoscopy showed mild to moderate left-sided colitis with significant lymphoid nodular hyperplasia throughout. Histopathology indicated foamy histiocytes in lamina propria and negative for H. pylori and gastric, and mild chronic typhlitis, colitis, proctitis with foamy histiocyte infiltrates in lamina propria. Stain for AFB is also negative. At this point, we advise for the parents for the further workup for liver biopsy, but parents are not willing for any further workup, and they went back to hometown and came back after 3 months here and with similar complaints, similar findings of increased transaminases and significant hepatosplenomegaly. We done an ultrasound guided liver biopsy for the child, which showed large macrophages with lipid-laden like appearance, which is negative for PAS stain and positive for colloidal ion involving primarily portal tracts and sinusoids associated with microvascular PAS hepatocytes or in favor of lysosomal storage disease. He also sent for electron microscope, showed extensive inclusion in the hepatocytes suggestive of lipid storage disorder. And we also send the genetic test which confirming the diagnosis of NIEMANN disease type A and type B. We then supported treatment for the child, and we also discussed with the hematologist. Bone marrow transplant is not advisable. Liver transplantation not a proven treatment for this child. Coming to NIEMANN disease is a group of autosomal recessive disorder associated with splenomegaly variable neurological deficits due to decreased activity of acid sphingomyelinases, categorized from A to D. Clinical features vary according to the type of disease, organ involved, and also the age of presentation. Some of them are hepatosplenomegaly, CNS features like delayed milestone, spasticity, intention tremor, hearing loss, respiratory distress due to pulmonary involvement. Type A and type B due to gene mutations of SMPD1 gene, and type C is due to gene mutation of NPC1 or NPC2. There will be deficiency of acid sphingomyelin in type A and B, and in type C, intracellular trafficking of cholesterol will be there. In type A, onset will be early in infancy, and type B, there will be onset in childhood or adulthood, and type C, the onset will be variable. There will be progressive neurological impairment in type A and little neurological impairment in type B and variable in type C. There will be cherry red macula in type A and B and saccades in type C. And all the types having hepatosplenomegaly and also having the recurrent respiratory infections. The diagnosis is mainly based on clinical examination, biochemical marker studies, and genetic test. Enzyme studies of lysozymes in leukocytes showed acid sphingomyelin deficiency. There was no cure for Niemann-Pick disease, especially type A. In other less severe form, treatment is mainly supportive. Miglustat is the only disease-specific oral therapy approved to treat progressive neurological impairment of Niemann-Pick disease. Other forms of treatment such as bone marrow transplantation or liver transplantation are not proven yet. The parents of the affected child should be offered for genetic counseling. Take-home messages: consider metabolic storage disease in an infant presented with hepatosplenomegaly, neurological disease, and developmental delay. Niemann-Pick disease can present from infancy to late childhood. Clinical features and prognosis varies between different types. In our case, chronic diarrhea was an unusual feature. Diagnosis confirmed by liver biopsy and genetics. Thank you.